this week. So it's definitely been a little challenging. The good news is no employee or patient data was compromised in this malware attack. They just took all of our servers down but didn't access our vaults. So that's what's going on. Besides the pandemic, I've actually forgot about the coronavirus this week with everything going on. But this presentation I originally did last year at IDAP, and so I've updated it for you guys today, and it's really funny to me because probably about 12 years ago, Glamour magazine called me and asked me if I would do an interview on orthorexia. And literally when they called, I was Googling what orthorexia was. I didn't even know what it was. I thought it was related to over-exercising and like healthy eating. I didn't really know. And so at the time, I declined doing the interview with Glamour magazine. And the reason is because the week before I was doing an interview at the University of Utah, and the professor had called me and said, Nicole, we know you're talking about body image, but could you add a few slides about Tanorexia? And believe it or not, I actually agreed to do a talk on Tanorexia. And the reason is, so this is me when I was younger in high school, and I kind of suffered with Tanorexia, and this is prior to my eating disorder. So some of you that know my story know that I've been recovered from an eating disorder for 29 years. And I developed my eating disorder in college, so please don't try to figure out how old I am now. But when I was in high school, prior to developing my eating disorder, I guess you can see the roots and the seeds, because I was insecure about my body, and I only felt comfortable if I was tan. And so I would go tanning, I would go to tanning beds, I'd go to, I was in tanning salons all the time, and I literally felt better if I was tan. So I like to use this analogy with my patients, saying, even if you felt better in your eating disorder body, or you feel more comfortable in it, it doesn't mean it's healthy for you. And again, I use myself as an example. If any of you were here for our January conference, the week before I had just had surgery because I had melanoma. And I'm fine and I'm good. And luckily they were able to get it all. But that is a direct result of my behaviors back then. So anyway, I declined to talk on orthorexia, and here now I've been speaking on it all the time. So we're going to talk about the history of orthorexia. We're going to talk about the current scholarship, the state of the research on it, risk factors, and then treatment and therapeutic considerations. So my hope for all of you is that by the end of this talk, that you're going to know as much as everyone knows on orthorexia, because there's not a lot of research, there's not a lot of treatment studies out there, and so hopefully you'll all be experts. So the term first came out in 1997 by Dr. Bratman, and he was seeing this in his patients. He was an MD. He was seeing his patients that had extreme diets, that really cared about their health. A lot of them happened to be yoga practitioners as well. And Dr. Bratman has now come out and said that he believes he had some of orthorexia. He himself was obsessed with where his food was coming from, the quality of his food. And he says he kind of got to his breaking point at a dinner party when he was missing the dinner party because he was out in his garden trying to get beets. And so he said he realized he had an issue. So orthorexia starts very simple in the beginning, kind of choosing to eat healthy. We know for many of our patients, and I know myself, that's how my eating disorder started. Up to 25% of our clients just decided to eat healthy and to go on a diet. So the second phase, though, this is where it gets a little more unhealthy. And these were patients literally start harming themselves. So if we look at some of the research on this, whoops, I seem to be missing a slide there, so we'll just skip over that really quick, but I'll kind of tell you what the second phase involves, and that's more where they're getting more obsessive about it. It's taking up time in their life, and we'll get into some more details about that. So when orthorexia really came out, there was a lot of backlash. I know I have a cousin that's a devout vegan in his own words, and he didn't like being labeled by this, and a lot of the people like dieters and paleo dieters were saying, hey, we don't have an eating disorder. And I think they're right. And so we're going to look at what the research says and where we draw that line between the healthy eating and what becomes very unhealthy. So some in the second stage, what we really see is this obsessive thinking, the compulsive behaviors, the self-punishment, and then the escalating restriction. So that's when we really know it's getting a problem. This is the slide I was talking about. Here it is now. So I know it's just out of order. It's fine. It just goes with my day. So when we look at the symptoms, we see with these patients, they're more concerned about the quality of their food than the quantity. This is where, for me, it becomes very problematic working with these patients. They're scrutinizing the source. So one of my patients, for example, she will only purchase food from local farms and markets. So she goes to the markets, but she goes down to the detail and wants to know where the food was grown, on what farm, and then she tries to look at the pesticide history of that land. Because as we know, pesticides can live in the soil for like decades. So then if she decides a pesticide had been in that soil, she still won't eat the produce from that land. So for some of my patients, I see them take it very, very far. And of course, they don't even feel like nutritional labels provide them with enough information. So really looking at, is this food good? And it usually has to have no processed foods, of course, and we'll get to some of that later. That's why dietitians are crucial if you're working with a patient with orthorexia. So some of the other symptoms we see, and this is common with all eating disorders, of course, is feelings of guilt if they're not following their guidelines, increased amount of time thinking about the food. They're doing a lot of advanced meal planning. So this is a picture that one of my patients, she does very similar to this. So she actually sent me this picture to describe what her meal planning looks like. This next one, I think, is another one becomes very problematic with working with this population, is they almost get a spiritual fulfillment from eating healthy. And so we're going to talk about that, especially when we get to the treatment implications. But they feel spiritually whole when they're eating this way. And then they have very critical thoughts about others who don't follow their diets. So I can safely say this, you guys are all in Idaho, so you won't know my daughter's boyfriend's mother. And she is a Pilates instructor here in Utah, and I love the woman. She is great, but honestly, I do believe she would fit under this orthorexia criteria we're going to be talking about today. And she's very kind, but she is very critical of any food other people eat. And she will really point out to them how unhealthy their food choices are and that they really need to be making better choices for their health. She doesn't focus on weight, but for their health. And so we're going to talk about more on how that can alienate people from others. So we see other symptoms as these people, it's very hard for them to eat away from home because they can't comply with their diet. When I talk about some high-risk groups, athletes are in this area, and I was asked to consult with a jazz player here for the Utah Jazz because when he was flying with the team, he required the trainer to bring his own food in a cooler because he did not trust the quality of the food being served to him in the other venues. So you can see where it starts to get problematic because they didn't want to pack coolers for him and put them on the chartered jet, and they felt like this was a very unreasonable request. And so we're going to talk about sometimes intervening with this population. This jazz player did not want my help whatsoever. He did not want to consult with me. It's usually the trainer reaching out going, hey, we have an issue. So again, they avoid eating food prepared by others. They distance themselves from family or friends, or family and friends could distance themselves from these individuals too, because they criticize them. And then we can see the depression, the worsening mood, other things. And this is probably where a lot of you see this show up in your practice. Many of these patients have had medical problems. And because of that, they're put on these diets that are supposed to be helpful for them. and they've maybe given some medical advice to do it, or as we see here at the Center for Change all the time, they present with food allergies, but they have no medical documentation to back up their allergies. So I'll use myself as an example. Some of you know I'm already completely self-conscious about what I call my man hands. So since you can see me, this is great. So you can see how I camouflage and conceal my hands is that I always have my nails done. I wear jewelry so that I can make my hands look more feminine. Since I have my dad who's 6'4", I have his identical hands. So I'll give you an example of what happened to me last summer. One of my friends, I was sitting next to her, and my hands do get a little swollen, especially we were at an outside professional soccer game, and my hands were swollen, my rings wouldn't come off. And so she looked at me and she said, Nicole, you really need to stop eating gluten. I really think that is your problem, and if you worked on your diet, your hands wouldn't be so swollen. Now that was really sweet of her to say, but I'll tell you what she does for a living, and she's really good at it, but she's a Mary Kay consultant. She's not a medical doctor. She's not a dietitian. But for a minute I literally thought, should I stop eating gluten? Like, is that why I have man hands? No, of course not, right? So you can see how within the culture, most of my friends think they're gluten intolerant now because it makes them not feel well when they eat it. So you can see how with this population, that could really become an issue. Same with they like herbal remedies, probiotics. They're very reliant on that. By the time we see them in 24-hour care, some of these patients have really narrowed their foods down to maybe even 10 foods. So I really can kind of compare these patients sometimes to the ARFID patients that could come in very narrowed down on their food as well. But of course, their food choices are very different, the orthorexia patients. So the other thing we really see is they're worried even about how we prepare our food. We've had several patients ask at what temperatures we sterilize utensils and our plates. They ask how our food is prepared. So for a lot of them, they can focus on that issue too. It's all about really taking care and concern about your food, where your food's coming from, the quality of it. So let's get to the research and kind of talk about, so as you can see, the very first really research journal on this is 2004. So do you see why I'm saying you guys are going to be experts here by the end? Because we're going to cover the whole thing. So 2004, first study, and he found Italian sample, 404 Italians. They used the Ortho 15, which we will be talking about. He found that about 6.9% of the population had what he called this orthorexia, or kind of manic obsession. So the Ortho 15, here's some of the questions. As you can imagine, it does have 15 questions, and it's asking about, look, do the thought about food worry you for more than 3 hours a day? You know, are you eating alone? So it's really kind of looking at how people eat, how much time it takes. So that was the measure he used. First measure out there, looking at this new kind of syndrome that we were describing. So then some other points in the research. So in 2005, we have the next case study that came out, 28-year-old female, BMI of 10.7. And she was told to eliminate fats from her diet to control her acne. Now, I have had in the last year seen 3 other patients that have developed kind of orthorexia traits and anorexia, and we'll tease that out when we get to the treatment section, but all after they were told by a doctor to change their diet because of their acne. Now, of course, I can remember when I was a teenager and I had pretty significant acne at age 15. My physician as well told me to stop eating chocolate and stop eating fried foods, and I think I did it 3 days, and then I went back to normal eating. Obviously, at that point in my life, I was not that vulnerable, so I wasn't vulnerable to continue dieting. But when I was 19, and I was told in college not to gain the freshman 15, obviously then I was vulnerable, and I heard the message. So you can really see with a lot of these patients, who gave them the message and how vulnerable were they at the time. The next one, 30-year-old male, only was eating brown rice because of a tic disorder. Again, the next case study, 33-year-old female, obsessive of just kind of healthy eating. So I love Jessica Setnick. I know she's done some things with your group and has done her boot camp there. So she was the first one to come out with diagnostic criteria back in 2013. I honestly think I'm going to present you several different versions of diagnostic criteria. Now, this may be because I love Jessica, but I do feel like hers are the best. Let me tell you the other reason I feel like hers are the best. Because out of all the other diagnostic criteria out there, she is the only one that actually practices in the field. So I think she has a pulse on what she's seeing with her patients. So she was really saying, again, these patients have a preoccupation with nutrition and diet far beyond what's necessary for health. And it's not, again, we all should care about our health, but she's saying this is extreme. Phobic avoidance of or response to foods perceived to be unhealthy, severe emotional distress, persistent failure to meet nutritional needs. So this is really important. So again, we're seeing similar to like ARFID, these people are not meeting their nutritional needs. They're obsessed with their health, they're obsessed with their eating, but they're not healthy, if that makes sense. Insisting on the health benefits of their diet, despite contrary evidence. So we can pull up their labs and say, well, I know that you think eating your broccoli and cauliflower is really helping you be healthy, but your labs aren't demonstrating that. And then marked interference with their social functioning. So some other exclusionary things that I wanted to bring up, because we're going to talk about these in some of the new research, is she's saying, you know, this isn't a culturally sanctioned practice. That's not why they're changing their diet. And Jessica's saying, you know, this is really a drive for health rather than a drive for thinness. So keep that one in mind. We're going to have to talk about that one in a little bit. And it's not because of medical condition or anorexia or OCD. So then, I don't know if you guys remember the blonde vegan. I definitely remember her because all my patients were talking about her. And a lot of my patients followed her. And she had a lot of attention. She was this healthy, clean eater. And then in 2014, she came out and basically said, by the way, I have an eating disorder. I'm suffering from malnutrition and I need treatment and help. And so then after she got some treatment in 2015, she became the Balanced Blonde. And so I'll talk about some of the Instagram and that and how this is impacting our patients because they're surrounded by this. Okay, so now we first had the very first study in the US. So we're already at 2015. And this was the first peer-related journal article. So 28-year-old male, he had 3 years of not eating enough. By the time he ended up at Denver Acute, so he was a patient at Denver Acute. By the time he ended up there, he was only eating protein shakes and he was a BMI of 12.3. And he really felt he was healthy and doing really well. So if you look at the second author on this, it's going to be Dr. Dunn. And so now you're going to see, I'll explain to you how I get in the picture and how I start doing research on orthorexia here in a minute. So based on this first US study, they came out with their own criteria. And so similar to Jessica's, but again, these are all researchers. So my good friend, Dr. Dunn, who I'll show you, he does round at Denver Acute, but he doesn't treat patients on a regular basis. So again, they looked and they said this is like 3 hours, people spending 3 hours or more consuming or preparing their food. The other kind of criteria I wanted to bring out that they added was spending excessive amounts of money related to income on food. This one I can relate to because I would say even in my eating disorder, I had anorexia, then bulimia, and then binge eating disorder. So I kind of went along the continuum. But I would say in my anorexia phase of my eating disorder, I was a very poor college student. I lived in Northern California, and I would travel an hour and a half to this Whole Foods, I can't remember what it was called back then, grocery store in San Jose to purchase my food that I couldn't even afford, even though there was a grocery store right across the street from my dorms. So I was definitely spending more money on food I couldn't afford, thinking I had to for my health, even though I wasn't taking care of myself, right, at all. So again, with his criteria, they do acknowledge the obsessive compulsive feature. They think that's important, but they really say they're worried because no one's addressing the weight loss. So they're saying, if we're going to look at orthorexia, we need to talk about the weight loss. These people are failing to meet gains, and they're usually lower BMIs. So here's my friend, Dr. Dunn. And so he came out in 2016 in a large literature review of all the orthorexia studies out there. And he basically said, look, we have no studies in the US on this, just the one that he did. And he said, you know, this measure we're using, the Ortho 15, is culturally biased, he thought. He says it's not even a good measure. And so he didn't even think we could use this measure to measure orthorexia. So he decided to make his own criteria. So now we're on our third criteria. So we have Jessica's, we have the one from the Denver Acute group that Dr. Dunn was a part of, and now in 2016, Dr. Dunn teamed up with Dr. Bratman, you know, and some of you may have seen, they presented, Dr. Bratman presented at IDAP that year, and they talked about their new criteria. So they said, we need to focus on weight loss. We need to focus on shame of their self-imposed rules, that these people really feel bad if they don't follow their rules. And this is interesting, and this is where I completely agree with their criteria. They said, we need to focus on these patients actually have positive body image, but their self-worth and how they feel about their body depends on compliance with their healthy habits. So that now we're on our third set of criteria in in 3 years. And so the next thing he said is, we've really got to look at the prevalence, because if you look at what's out there on orthorexia, according to Dr. Dunn's literature review, anywhere from 6.9% of the population to 57.6% of the general population now has orthorexia. So obviously, the way we're measuring it is not accurate, because if half of society has it, we can't say that this is something we can diagnose, correct? So he went through and he looked at all the studies out there, all the research out there, all the different measures, trying to find a new measure. So I'll just kind of sum this up really quick. We'll just kind of advance ahead to what we decided to do here at the Center for Change. So basically, Dr. Dunn came here, and our goal, and what I was helping him with, is we were going to make a new criteria. So we were taking some of the measures of the EAT-26, we were taking the Ortho 15, and we were going to put all of this together, and we were going to make our own measure. And we thought we were just going to nail this. We had my clinical expertise, we had his research expertise, and we were going to make our own measure, and it was going to work perfectly. What we found is our new measure really didn't distinguish between orthorexia patients and other eating disorder patients. And so I highlighted the differences. We did find some differences, but not enough. So we see people with orthorexia, they were higher on the diet subscale. And then you kind of see that they scored higher than patients with bulimia on the food occupational subscale. But we really didn't find any significant differences, which wasn't helpful. So let's look at the brand new. This is right off, I call it hot off the press, brand new research study, just came out last month. So these researchers looked at 512 subjects. They basically found that, number one, eating disorders and OCD, they are different. They feel like individuals with orthorexia, it's not a part of an OCD. They do believe it needs to go under the eating disorder category, which makes sense. Look at the next one, which makes total sense in my clinical practice. They're saying orthorexia is tied to body image disturbances, which is what I've seen completely. You can give me a patient that you would describe as orthorexic, and they meet all the criteria, even if we go with Jessica's criteria, which I think is the best. If they meet all Jessica's criteria, when I start to weight restore that patient, they can't handle it. It's no longer just about health. It is now about body and weight. So this study really found that food choices are strongly motivated by weight control. So they're saying, you know, we think orthorexia is a thing. We think it's a sub-threshold of eating disorders. They're saying, you know what, though, we don't think it needs its own diagnostic category. So they're saying, you know, we see it, and that's exactly how I feel, honestly. I do see a distinction with patients, but what I see it is usually part of the anorexia phase for some of these patients, because I do see them then they like the weight loss, they don't want to gain weight, they don't feel comfortable with the weight gain process. So I see it very similar. But when you look at this study, when they ask professionals that work with eating disorders, do you guys think it needs greater attention? 69% of the people are saying, yes, it does. So we're all kind of seeing it in our practice. We're all saying, I think it is a thing. We just don't know what it is. So there is an orthorexia task force. So McGregor, this is her most recent book. She is on the task force, and they're trying, but you know, this was all before COVID. So their plan was to have criteria out in 2020, which Jessica is a part of that task force. So the plan was, we're going to make new DSM criteria. We're going to have our own criteria. The problem, though, is we don't really have a way to assess it. But I really like Jessica's statement on this. And she really said, you know what, you guys, it's not critical that we get a diagnosis on this. We still can treat it. She said, though, if we did have some criteria and a clear understanding, it could probably help us get research funding. It could help us with awareness, and it could help us with prevention. And she makes an excellent point, because right now we have no clear criteria. We all kind of see it in our practice. We know it's there. We don't really know how to measure it. And there's really not a lot of research. So I'm going to talk about the treatment considerations, some things we've done here at the Center for Change, some things I've personally done with patients and working with them, and then talk about the research we do know with risk factors and that. So we'll talk about the obstacles and barriers to treatment, why this population is so hard to get into treatment. We'll look at high-risk populations and then differences in treatment approaches. So first off the bat, there's limited research. There's really only case studies and a few cross-sectional studies. So we don't know a lot about how to treat these individuals. But honestly, maybe we all know a lot about treating these individuals, because if we just apply a lot of the concepts of what we're already doing with patients, I think you'll find that it really applies. Some of the problems, though, is society really praises individuals for healthy eating. And these patients really feel they're morally superior. So they're not going to want to come into our office. And so we'll see why they generally present in our office, because they don't usually want help. And so we can see, too, this ideological thing. So the spiritual piece is one reason why they really have a hard time coming into treatment, because they really feel like they're living their best life, they're taking very good care of themselves, and everything they're doing is for their health. So according to Dr. Bratman, and these are his risk factors, he says he's seen kind of an adoption of a highly restrictive dietary theory within families. So I'll give you an example. Last year, we admitted a 33-year-old female that I do believe met the criteria for orthorexia, and she was part of our research study. She only ate very few foods. The problem is she was raising her 3-year-old that way, and then she was also impacting her husband. So her husband called our dietitian furious because his wife was in here eating goldfish. And he said, I won't even let my 3-year-old eat goldfish. That is so unhealthy. How dare you? I can't have my wife coming home eating goldfish. And so you can really see that it can become part of the family system because they all embrace it. And what I've seen with a lot of my patients that I feel have kind of recovered from anorexia and even bulimia, they then kind of dive into orthorexia and they feel like that's recovery because they're like, Nicole, I'm eating plenty, but they're still obsessed with what they're eating. And so again, parents can place undue importance of healthy food. My sister-in-law, I'll tell you, she will not let her kids eat sugar. They can't eat sugary sweets or candies or anything. So they come to my house, and I have big, like, glass canister candy jars in my house, in my kitchen and that. My kids don't even touch it. Usually like right now, I think the pretzels in there are stale. I think the M&Ms are still good, but my kids don't touch it. But when my nieces and nephews come over, they're like eating it nonstop and they're sneaking it. And my sister-in-law got mad at me most recently because I guess my niece had put M&Ms in her pocket and they had melted, and so they had ruined her clothes, and somehow that was my fault. But it just goes to show, and you guys know when we put those restrictions on, right, it's not helpful. So other risk factors are childhood illnesses. So kids that have had some digestive problems or celiacs or Crohn's disease, these kids then, with good reason, have had dietary restrictions put on them, or within the family there's been dietary restrictions due to a medical problem, and so then they channel in on that. Or fear of disease. Most recently, I've treated 2 women that have come to me because they have Lyme's disease or fibromyalgia. They have been put on a diet by their doctor, and then they have become very rigid with that diet to the point where they can't break out of it. I'll use myself as an example. When my daughter was 3, she got mono. And so then I got mono. And I had mono for 6 months. And I was desperate. I went to a doctor and I'm like, I got to get rid of this mono. And he basically put me on a diet. And he said I couldn't eat any sugars, no caffeine, no trans fats. I literally lasted, I think, 4 hours. And I couldn't do it. I really felt it was triggering for me. I couldn't do it. And so I said, you know what, I'll keep the mono. Like I cannot mess with, as a recovered individual, I cannot mess with my diet like that. And I eventually recovered from the mono, but I can see how it can happen. So when we look at high-risk populations, of course, women in the research, but I really feel like men are a high-risk population. Adolescents, we'll talk about athletes. And then look at this. If you do yoga, no offense, but some research says up to 86% of yoga practitioners struggle with orthorexia. So if we look at other high-risk populations, the research has found physicians, medical students, all my dietitians. Oh my gosh, you guys all have orthorexia according to the research. 81% of you, a most recent study in 2017 says up to 50% of dietitians are consumed with what they eat and the health of what they eat. Again, this is all based on inadequate research and not great tools. So any of the research, if any of you were at my IDAP presentation, basically everything I presented, then Dr. Dunn got up on stage and just said, forget everything she said because none of the research is good. And he has a point. So all the research I present, just know that we think it's a little bit flawed, but we do see performance artists struggling with this. So for men, we're seeing an increased trend in men. And I think it's because of a lot of the media, the social media. When I do a whole presentation on social media, we see, for example, Tinder in general. Men are reporting feeling so self-conscious about how they look, and that men now maybe feel like they need to look better and have better health because of that. I cued myself to talk about the USA Today article. Some of you may have seen it. It came out 4 years ago. Here's the headline. So don't get mad. I'm glad you can't throw anything at me. What it says is, number one thing married men want to change about their wives. Number one thing. So this is the headline on USA Today. Number one thing married men want to change about their wives was their weight. So we thought, oh my gosh, these men are jerks. What is wrong with them? No, these men are actually really sweet. They wanted their wives to lose weight because they knew their wives wanted to lose weight. So they wanted a happy wife. So then they asked married women, number one thing you want to change about your husband. Well, I want to teach my husband how to load the dishwasher correctly and not leave the dishes in the sink. So that would have been what I would have put on the survey. But the number one thing married women wanted to change about their husbands was their weight, once again. But when they drilled down, actually, these women were very kind as well. They were worried about their husband's health. So a lot of times we're seeing men dieting and changing their food because of their health, not necessarily because of their weight. So we see with the men, the social media, we're seeing orthorexia kind of tendencies hit younger males, and they're trying to maintain these kind of lower weights. I think too, I just look at the men's styles with these skinny pants and different images now that are out there with men. They're getting the same pressure that women have gotten all these years, and now it's happening to men, I think, at even higher rates. And now we'll talk about athletes. This is an area I work with a lot. I mentioned the jazz player that reluctantly declined he reluctantly declined to work with me. So I did work with a trainer, but I have been consulting with a lot of professional MLS players that are definitely struggling with what I would call looks very orthorexic. For a lot of them, they have been able to maintain their professional status and starting doing some of this clean eating. What we find over time, just same with when working with our women with eating disorders that are athletes or other men, whether it's orthorexia or not, is when they first develop some of these symptoms, their performance improves. Over time, we see their performance decreasing. That's usually when I get involved because they're trying to get these athletes to eat a variety of food. They're seeing it's impacting their health, but it's really hard to argue with a professional athlete that's at the top of their career that we're concerned and you're not doing a good job. So it's usually after they've had multiple injuries that the trainer will call in the psychologist to try to help them with this. But like I said, they're not usually a willing audience because they think what they're doing is good. But that's how I've been involved, and I have had a little more luck. I'm working with a coach right now, and we're trying to expand what he's eating because he's really only eating certain food groups, certain food types. So when he's traveling with the team, he's having to Uber in food because he will not eat if it doesn't meet his requirements. But we're kind of making baby steps with him. So other things, of course, the research says up to 30% of men that are athletes, 28% of women can struggle with this. And again, they have very strict eating schedules. They have training and they care about their health a lot. So I'm going to skip through some of these slides so we can get to the treatment section. So we're going to talk about treatment, medication management, and dietary. So there's really not a lot of studies, only 15 studies on treatment. So know that there's not a lot of research there on treatment. But these patients usually will maybe come into treatment after the family pressures them, after a coach pressures them, or if they're feeling extremely guilty and that self-loathing is really high. So some of the interventions I want to go over that I found work very well with this population is first, getting some consistency and structure. I like them to kind of give me a general idea of a meal plan, not exactly what they're going to eat, right? But they'll tell me I'm going to eat breakfast between 8 and 9. I'm maybe going to have a main and 2 sides, maybe one of those sides is going to be a little more challenging. So this is, and I'll get to why dietitians are crucial in this treatment, but you could do a hierarchy of their challenging foods. And so then you can systematically desensitize them, that maybe we start with one of my patients, literally, I think we started with non-organic produce. So it was still had to be produce, but it was not, it was just regular produce she bought at Target, not that she bought at Whole Foods and was organic. And so that was our slow progression. So setting very small, obtainable, measurable goals are crucial. So other things is really looking at their triggers. What in their environment? And with this population, they could be surrounded. One of my patients right now, she works in a gym as a personal trainer, and she's trying to overcome kind of her orthorexia tendencies. So really looking at their environment, and they're bombarded in the media that they're supposed to be eating this way, reaching out for support. It's crucial. So for all my dietitians listening, I always say you guys get voted off the treatment team first, because my patients say, well, I can't afford it. Insurance doesn't cover them. I already know everything. No, if you are a therapist listening and you work with eating disorder patients, your dietitian is a required part of the team. And so I refuse to see patients if they will not work with a dietitian. So making sure you have that comprehensive treatment team. Medications, I believe, are important too. Really looking at their friends. A lot of them are surrounded by people that do very similar behaviors. So maybe having them branch out and get support in other areas. And so again, the importance of the dietary team. There's Jessica again. Just love seeing her face. But I think a lot of you have seen her clinical pocket guide. It is excellent. I have it on all my therapists' desks. It's a great resource. But she has some assessment tools there. And so I put them on here so you can see, kind of looking at how much these patients are spending, planning, preparing food. Are they eating alone or with family? What's their levels of guilt? And is your eating style supportive of your lifestyle? That was one reason I recovered. I knew I could not keep that lifestyle. It was not getting me where I wanted to be. So really having your patients look at that. We're going to, this is the other reason you need a dietitian on your team. These patients can run circles around me. I have watched every documentary on clean eating that's made on Netflix, and Amazon Prime, everything, just trying to keep up with trying to argue with these patients. So dietitians can be very helpful in this area because there's a lot of false information out there. And so I think it's very helpful, again, to have them on your team. Looking at places they avoid, restaurants they avoid, grocery stores they avoid. Here's another one we see in 24-hour care with these patients. They won't even drink our Boost or our Ensure. So if patients don't eat 100% of their meal, they're given the Boost or Ensure option. Orthorexia patients that fit into that category usually refuse, and they want their parents to send in a separate supplement that's organic and has no chemicals in it that they can eat. So we usually do have to screen for this to see if they will take this nutritional supplement. These are other things they tend to avoid. It's a large list. So it gives you an idea of how challenging these patients. But again, it's very similar to our patients with anorexia, but they take it to a whole new level. So other things you want to look at is exposure and response prevention. We will take these patients to the grocery store. We will take them out to restaurants. So even during COVID, we're not taking them out to restaurants anymore. We bring in food. And so we do kind of that response prevention as well, getting them to eat more challenging foods, looking at foods they used to really enjoy and introducing those back into their life. And then looking at the medical. So I just kind of highlighted, this is what the research found with patients with orthorexia. And these are some of the medical things, but I wanted, if you have not, if you don't have Dr. Guadiani's book as a reference, I think it's a really user-friendly book for professionals. So I'd highly recommend it. She's got a series too that you can buy. It's basically 18 recordings that we use with our medical staff. It's excellent. So again, having the medical team, important. Looking at medication. Now, what you're going to find, individuals with orthorexia, I would say avoid and refuse to take medications equivalent to anorexic individuals struggling with anorexia. They avoid it. I have 4 patients with these characteristics on my inpatient unit right now that I cannot get to take medication because, again, they see it as a toxin. So the next one is really getting the family involved. I think it's critical with this population because maybe there's been a lot of distancing from the family. So I do like all my patients to write a 10-page eating disorder auto where they put all of their behaviors in there. They share it with their closest support people. I like it to be 5 people. That could be the therapist, the dietitian, the medical provider, a friend. Who is their support system? They share it with their support system so that they can start getting some connection and some support because social isolation is so big. And then being honest. I like what I call the 24-hour honesty rule. I made up this rule myself because I was such a liar in my eating disorder. I would lie to people's face. So I have a rule that within 24 hours, my patients have to be honest with their accountability person and that they have to propose a self-correction. So if they did a behavior, they propose how they're going to self-correct. So I did this with a patient last night. I'd asked her to eat 50% of her meal. I found out this morning she did not do it. So apparently if I go up on the adolescent unit, she has written me a 2-page self-correction paper on why she didn't do it. So after I'm done with this, I'm going to go read that paper. So again, always teaching them though, we're moving forward. We're moving forward. Self-correction, it's not punishment, it's moving forward. Looking at social media, I know I'm running out of time. Couple things really quick. Instagram is the highest for orthorexia. So Instagram has tried to get rid of all the dieting things on there, but the most recent research that just came out in December of 2019 says Instagram is the breeder and the fueler, they feel, of orthorexia. So I like to ask my patients what they follow, who they follow, looking at that. A large study that looked at 22 clean eating blogs and sites. They had to win an award. They had to have a large, over 100,000 followers. So these were large clean eating blogs or sites. They did a content analysis. They determined 19 of the 22 they felt met the criteria for an eating disorder. So talking to our patients about that. Service. I'd like to get these patients out volunteering any way they can. Now with COVID, even if it's a virtual volunteering, even if it's going to the animal shelter and walking a dog, that's what a lot of my patients do. They're so kind. They love animals. So any way I can find to get them outside of themselves, looking at their environment. So one of my orthorexia patients, she works at a raw vegan food truck. I told her, no, this is not helpful. So really having them look at their environments. The next one is spirituality. This is so important with this population because they believe their behaviors are making them more pure. So having them find their other passions and interests. Dr. Ira Sacker, he has a great book out there about helping patients discover their passions. I think it's really important. My patients have said just exploring their spirituality. If they do go to church, going back to church. A lot of our patients in the eating disorder stop practicing their religion. So encouraging them, if that's important to them, encouraging them to get back to that and their higher power. So the very last one is self-care. I like them to work on their self-care, actually scheduling self-care, journaling, affirmations, relaxation. If any of you are on Instagram, even though I've just said how toxic it is, I do have an Instagram site. It's just Dr. Nicole Hawkins. And it's all dedicated to eating disorder recovery. And I post different things about self-care, or I post research on affirmations. I post research on the brain. So you're welcome to check that out with some more insights. So I know I am out of time, so thank you so much for bearing with us. This has been actually the best part of my week, talking to you guys. So I apologize for our technical difficulties. We are hoping our email systems will be up by this weekend. So, but thank you everyone for spending your lunch hour with me. It's a great honor to talk to you, and I'm so sorry. I was so excited to come to Boise in person. So Tamara, do you have any further announcements? No, just they'll get the email for the test, right?
They will. You did.